Welcome to this presentation. This will be a lecture on Cognitive Behaviour Therapy, CBT. We will first look at the rationale for CBT. We will briefly look at the history of development of CBT. We will focus on the use of CBT in depression and anxiety disorders. At the end, we will go through 5 multiple choice questions. Some information about myself. I am a consultant psychiatrist based in Chennai, which is a city in southern India. I have worked for many years in the United Kingdom. So, what is CBT? CBT is a type of psychotherapy. CBT stands for Cognitive Behaviour Therapy. Cognition refers to thoughts. Behavior refers to actions. What is the rationale for CBT? One's cognition and one's behavior can have an influence on one's mood. Negative cognitions and maladaptive behaviors can lead to depressed mood. Therefore, by identifying and correcting negative cognitions and maladaptive behaviors, the depressed mood can be improved. So this is the rationale for CBT. Aaron Beck is generally considered the pioneer of CBT. He was a professor of psychiatry at the University of Pennsylvania in the US. He initially developed cognitive therapy for treating depression. This therapy was subsequently expanded to include behavioral components and became cognitive behavioral therapy. Since then, CBT has been used successfully for a range of disorders, including depression, either on its own or in combination with psychotropic medication. This is Aaron Beck. We will now look at the use of CBT in clinical practice. CBT is a time-limited therapy, usually between 12 and 16 sessions. The number of sessions is typically decided in advance. Sessions take place once a week. Each session lasts for about 50 minutes. The goals of treatment are clearly identified at the beginning of therapy. Once therapy starts, the patient's progress is regularly monitored during therapy. In CBT, the patient is an active participant. The patient is generally given homework tasks to complete in between sessions. Rating scales are usually used at the beginning of therapy and also at the end of therapy to assess effectiveness or otherwise of the therapy. In CBT, the focus is on the here and now. The focus is not on the origin of the problem. The main objective of CBT is to help the patient use practical cognitive and behavioral strategies to overcome their problem. In this slide, I have highlighted some differences between cognitive behavior therapy and exploratory psychotherapy. By exploratory psychotherapy, we include psychoanalysis, psychodynamic psychotherapy, etc. So if you want, you can pause at this point and go through this slide. The initial assessment is important. It should include description of current difficulties. Realistic goals of treatment need to be identified. The treatment rationale should be explained to the patient. You need to establish whether the patient would be willing to work in a CBT model. Clearly explain the structure and purpose of the treatment sessions. If suitable, you can then start treatment. So each treatment session should have a clear structure. You should agree on an agenda for the session. Review the progress since the previous session. Review homework tasks given to the patient at the last session and inquire whether there were any difficulties in doing them. Discuss in detail a specific problem or difficulty that the patient is experiencing. Devise specific strategies to address that problem. Give homework tasks with clear instructions and get feedback from the patient and ensure that the patient has understood. We will now look at CBT in depression. The aim is to overcome negative cognitions and unhelpful behaviors that serve to maintain the depression. Examples of negative cognitions can be I am worthless, it is all my fault, I will never get better. Examples of unhelpful behaviors include social withdrawal, avoiding activities, staying in bed for long periods. In this slide, I have listed 3 key terms that are used in CBT in depression: dysfunctional assumptions, negative automatic thoughts, cognitive distortions. Dysfunctional assumptions are extreme and inflexible opinions that people form about themselves and about the world. People's early life experiences influence what dysfunctional assumptions they develop. Examples of dysfunctional assumptions: if I am not perfect, I cannot be happy. If I don't succeed in everything I do, I am a failure. Dysfunctional assumptions remain latent until there is a critical stressful event, when they then lead to negative automatic thoughts. Negative automatic thoughts are called so because they are negative, that is, they have negative themes, and they are automatic. These thoughts keep popping in one's mind. The content of negative automatic thoughts tends to be related to the dysfunctional assumptions that precede them. Examples of negative automatic thoughts: I will never be happy, I will always be a failure. Negative automatic thoughts then make the depression worse. Cognitive distortions are errors in thinking that are commonly seen in depression. These cognitive distortions serve to maintain depression. CBT aims to identify such cognitive distortions and helps the patient to correct them. This process is called cognitive restructuring. In this slide, I have listed some types of cognitive distortions: all or nothing thinking, jumping to conclusions, magnification, minimization, overgeneralization, and disqualifying the positive. We will look at them one by one. All or nothing thinking refers to thinking in absolute rather than in relative terms. Words such as always, never, everything, nothing, these words characterize all or nothing thinking. Let us look at an example. A person applies for a promotion at work. He does not get promoted while another colleague does. He then concludes, I will never get promoted, or I am always a failure. Jumping to conclusions refers to coming to negative conclusions with insufficient evidence. There are two types. The first one is mind reading. For example, at work, a colleague does not smile back. The person then concludes, he no longer likes me. The second type is fortune telling. The person fails his driving test the first attempt. He then concludes that he will never pass the driving test. Magnification and minimization. The person with this cognitive distortion tends to magnify his or her mistakes while minimizing any positive achievements. Example, magnification. The person fails to meet a deadline at work by just one day. He feels very guilty about this. Minimization. The same person succeeds in meeting a deadline at work several days in advance. He, however, dismisses it, feeling that he was just lucky and therefore deserves no credit. In overgeneralization, the person makes sweeping generalizations from an isolated example. The patient prepares dinner for friends. Apart from one item, all the others come out very well. However, the person generalizes from the one poor item and concludes, I am a terrible cook. Disqualifying the positive. In this, the patient dismisses any good attribute of oneself. And you can use the same example as in the previous cognitive distortion, overgeneralization. We will now look at the CBT techniques used in depression. Cognitive strategies include identifying and challenging negative automatic thoughts, distraction techniques. Behavioral strategies include monitoring activities on mastery and pleasure, scheduling activities, and graded task assignment. In order to identify negative automatic thoughts, the patient is asked to maintain a record of negative thoughts that keep popping into their mind. These negative thoughts usually involve one of the following three themes: about oneself, such as I am worthless; about the world and others, no one cares for me; and about the future, there is no hope for me. Once the negative thoughts are identified, the patient is advised to challenge them to establish how true they are in reality. By repeatedly doing this exercise, the patient would be able to see the link between low mood and negative automatic thoughts, and between challenging the negative automatic thoughts and improvement in mood. In this slide, I have given an example of a record of negative automatic thoughts. So in this situation, the patient's manager makes a harsh criticism at work. As a result, the patient gets the negative automatic thought, I am always a failure. And at this point, the rating of depression is almost maximum, 95% out of a total of 100%. The patient then rationally challenges the negative automatic thought. I have succeeded many times previously. This criticism by the manager is more a reflection of bullying on his part than a failure on my part. Even if I had made a mistake, I will use this as a learning experience, because everyone makes mistakes. And then the depression level falls to 40%. So this is an exercise that the patient is asked to do regularly. Distraction techniques are useful when one is extremely distressed because of symptoms of depression or anxiety. By distracting oneself from depressive and anxiety thoughts, the patient can reduce the acute severity of these symptoms. They are useful in the short term while the patient is learning other CBT techniques. Examples of distraction techniques include focusing on an object, doing some mental exercises, thinking about pleasant memories and fantasies, sensory awareness, and doing some absorbing activities. In focusing on an object, the patient is taught how to focus attention on an object. For example, the patient is asked to look at an object nearby, such as a wall clock, and asked to mentally answer several simple questions such as what is its location, how big is it, what is its color, what is it made of, what time is it showing, etc. Examples of mental exercises include subtracting back from 1000. So you subtract, for example, 6 sequentially. Thinking of objects beginning with a certain letter of the alphabet. So the patient is asked to think about past pleasant memories or possible future fantasies. Examples: thinking about a previous holiday that the patient had enjoyed, or what they would do if they win a large amount in the lottery. In depression, especially if it is severe, it might be difficult for the patient to recall or contemplate about anything positive. Indulging in some activities that can distract the patient can be helpful. For example, doing a crossword or a Sudoku puzzle, listening to music, or watching a favorite program on television. Sometimes any physical activity such as cooking, cleaning, ironing, etc. can be helpful. Again, if the depression is significant due to reduced mental concentration and increased physical tiredness, the patient may find doing these activities difficult. Behavioral strategies include monitoring activities, scheduling activities, graded task assignment. The patient is initially asked to keep a record of all the activities that they do on a daily basis. The patient is then asked to rate each activity on a scale of 1 to 10 based on the following: mastery, how well did you do the activity, and pleasure, how much enjoyment did you get while doing this activity. This would be an example of a record of activities. If you want, you can pause at this point and spend some time looking at this slide. This monitoring record of activities that the patient does every day helps to counter negative thoughts such as I don't do anything, even if I do something, I don't do it well, I don't do anything that gives me pleasure. Because the record of activities would show that the patient is actually doing certain things, and there are certain things that the patient does well, and there are certain things that give the patient pleasure. The next step is scheduling activities. The previous task would give an idea of the kind of activities that the patient is able to do and also able to enjoy. The next step is for the patient to plan each day in advance, preferably on an hour-by-hour basis. The number of activities should, however, be realistic, considering the severity of the patient's depression. The patient is asked to include activities that they enjoy. Planning in advance helps the patient have a greater sense of control, and it also helps to avoid the patient have to repeatedly make decisions during the day. The next step is graded task assignment. If the patient is unable to do a particular task in one go, he is advised to break such a task into smaller, more manageable steps. This grading helps to overcome procrastination, negative cognitions such as it is too much for me, and hopelessness, I can never do this. We will now move on to CBT for anxiety disorders. CBT has been shown to be effective in a range of anxiety disorders, including panic disorder, phobias, obsessive compulsive disorder, generalized anxiety disorder. We will go through some of the important features of each anxiety disorder. Panic disorder is characterized by episodic paroxysmal anxiety. The anxiety attacks come out of the blue. In panic disorder, there are both cognitive symptoms, example, fear of fainting, fear of dying, etc., as well as physical symptoms such as palpitations, sweating, trembling, etc. Panic symptoms can also occur in phobic disorders in response to exposure to the feared stimulus. This slide highlights the relationship between physical symptoms and associated cognitions in panic disorder. So physical symptom like palpitations may be associated with the fear, I'm having a heart attack, I'm going to die. The physical symptom of breathlessness might lead to the fear, I'm going to suffocate. Feeling dizzy might lead to the fear, I'm going to faint. Phobia is an anxiety disorder in which symptoms occur when the person is exposed to the feared stimulus. Depending on the stimulus, there are different types of phobias. Simple or specific phobia, agoraphobia, social phobia, or common types of phobias. In simple or specific phobia, the anxiety symptoms do not occur in the absence of the feared stimulus. Examples include fear of spiders, heights, enclosed spaces, etc. In agoraphobia, the patient has a fear of crowded places or traveling alone or leaving home. In severe cases, the agoraphobic patient becomes totally housebound. Social phobia is also called social anxiety disorder. In this condition, the anxiety symptoms manifest in social situations such as attending social events such as parties, public speaking, or sometimes even eating in public, as in restaurants. In anxiety disorders such as panic and phobias, the behavioral response of the patient to overcome the anxiety is usually one of the following two: avoidance and escape. So if the patient knows which situation triggers the anxiety, he or she may avoid that situation. Or if the patient develops anxiety in a particular situation, they try to leave that situation. So that would be escape. CBT aims to change such maladaptive behaviors and helps the patient deal with the anxiety. So avoidance and escape may provide short-term relief of anxiety, but in the long run, they reinforce the anxiety. Obsessive Compulsive Disorder is a disorder characterized by obsessions and compulsions. Obsessions are repetitive, intrusive, unpleasant thoughts that keep coming up in the mind despite the patient's attempts to resist the thoughts. So they are different from the negative automatic thoughts that we saw earlier. Obsessions are characterized by the patient's attempts to resist the thoughts, whereas this resistance is not seen in the case of negative automatic thoughts. Compulsions are repetitive behaviors that are done in order to reduce the anxiety associated with the obsessions. So examples of obsessions include fear of contamination, fear for one's safety or the safety of others close to the person, such as children, need for symmetry. And examples of compulsions include repeated hand washing, repeated checking, and arranging. Generalized anxiety disorder is an anxiety disorder in which the patient feels tense or on edge most of the time. The anxiety in generalized anxiety disorder is referred to as free floating, in contrast to the out of the blue anxiety that is seen in panic disorder. Associated symptoms in GAD include muscle tension, being fidgety, restless, insomnia, headache, fatigue, difficulty concentrating, etc. We will now look at some CBT techniques used in anxiety disorders. relaxation exercises, exposure and response prevention, distraction techniques, identifying anxiety-inducing thoughts and finding alternatives. There are several techniques of relaxation. The main technique used in CBT is the applied relaxation exercise, which includes several stages. These relaxation exercises should be regularly practiced so that they can be used in real-life anxiety-inducing situations. The first stage is called the progressive muscular relaxation. In this, the body is divided into a series of large muscle groups, and each group is first tensed and then relaxed. By alternating between tension and relaxation, the patient is taught to distinguish between these two states. Initially, the relaxation exercises are taught by the therapist during the sessions. The patient then practices them when he is in non-stressful situations, example, while sitting in a chair at home. In due course, the patient is able to use these techniques in those situations that induce anxiety or when symptoms of anxiety have actually started. In exposure and response prevention, the patient is exposed to the feared stimulus, thereby overcoming avoidance. This stimulus would induce anxiety, but the patient is prevented from showing their habitual maladaptive response, which would have been escaping from the stimulus. The patient is advised a few general principles regarding anxiety symptoms, that however distressing these anxiety symptoms are, they will neither kill you nor will they last forever. In other words, if you are patient, the symptoms would eventually subside. The exposure to the feared stimulus is usually done in a graded manner, hence the term graded exposure. Studies have shown that CBT is effective in other disorders apart from depression and anxiety disorders, such as eating disorders including bulimia nervosa, non-organic sleep disorders such as insomnia, and non-organic sexual disorders. In addition, CBT in combination with other treatments, usually psychotropic medication, has been shown to improve outcome in psychotic disorders such as schizophrenia, bipolar affective disorder, alcohol and substance misuse disorders, and personality disorders such as borderline personality disorder. CBT is an effective treatment that has revolutionized the management of depression and anxiety disorders. In CBT, the patient is an active participant in therapy and is not just a passive recipient of treatment given by a professional. In psychiatric practice, CBT techniques are usually used in combination with medication in order to try to improve outcome. We have now come to the end of the lecture, but before we finish, we will go through 5 MCQs. Question 1. CBT is not indicated as monotherapy for which of the following disorders? By monotherapy we mean the sole treatment. So for which of the following disorders is CBT not indicated as monotherapy? Is it A. depression, B. OCD, or C. schizophrenia? If you want, you can pause and select your choice. The correct answer is schizophrenia. In depression and OCD, especially for mild to moderate depression and OCD, CBT can be used on its own, whereas in schizophrenia, antipsychotic medication is the first line treatment, while CBT can be used alongside medication for some patients. Question 2. CBT was pioneered by. If you want, you can pause now and choose your choice. And the answer is B. Aaron Beck. Sigmund Freud pioneered psychoanalysis, while Marsha Linehan developed dialectical behavior therapy, or DBT. Compared to psychodynamic psychotherapy, which of the following is true regarding CBT? If you want, you can pause now and choose your choice. And the correct answer is A. CBT gives little importance to unconscious processes. Total duration of CBT is not correct, because CBT is time limited, usually 12 to 16 weeks, whereas psychodynamic psychotherapy can extend for up to several years. And individual sessions in CBT are for 50 minutes generally, which is the same for psychodynamic psychotherapy also. Question 4. Exposure and response prevention is a CBT strategy used for A. mania, B. depression, or C. phobias. You can pause and select your answer. The correct answer is phobias. So exposure and response prevention is used for anxiety disorders such as phobias. The final question. In CBT for depression, all or nothing thinking is an example of A. dysfunctional assumptions, B. cognitive distortions, C. negative automatic thoughts. You can pause now and select your option. The correct answer is B. cognitive distortions. These three concepts are closely related, but they are distinct. So I suggest that you go through that section of the lecture where I discuss these concepts again for greater clarity. And we have now come to the end of this presentation. Hope you found the lecture useful. Thank you for watching.